Hi, I'm Catherine Bird and I'm the Quality and Safety Lead in Children's Services in North Cumbria. Thank you for inviting me to discuss my project today, and I apologise I can't be there in person. I was really looking forward to talking about how I've undertaken a quality improvement project in North Cumbria as part of my job role and for my 60 credit project for the Masters. Started my Masters 2.5 years ago. Can't quite believe I'm here presenting today my 60 credit project, having completed my Masters and my dissertation. Since starting the Masters 2.5 years ago, I've changed jobs. So this happened when I started my 60 credit project in January this year. And therefore it determined the project that I was to do. My previous roles had been physiotherapist. I'm a physiotherapist and some operational and quality and safety roles. And I was also the Trust Freedom to Speak Up Guardian. But there was pressure on me to find a project which worked for my new care group, but also worked for me. So I wanted to mould it to my skills, but I also knew that there was a balance to be had. So my project was, has the implementation of incident huddles within the care group improved the learning from low and moderate incidents for staff? And can we provide assurance that the learning is embedded in the practice? So it's very much a patient safety project, as improving the quality of learning from incidents determines better outcomes for patients. This in turn helps improve engagement with staff. So I was really excited to get started, as I knew the project would help introduce me into the care group and help me meet staff. So my project, it's firstly important to understand the context of where the Trust is presently. Cumbria is an organisation challenged geographically. North Cumbria Integrated Care Trust covers the whole county and stretches from Carlisle to Whitehaven down to Egremont. The organisation was two separate organisations, but has now come together as one. So the merger of the acute and community happened in 2019, and we're really still merging to this day. Changes obviously happen continually in NHS and in England. We've got over 6,000 staff on two main sites, Carlisle and Whitehaven, and we've also got 8 integrated care communities outlined on this slide here. So some of my main skills are influencing, negotiating, communicating with people, being an allied health professional and a previous clinical leader. So I was also aware of staff's perception of myself being in the Freedom to Speak Up Guardian role, as that was very much around culture in the Trust, and I was really aware that staff felt like the role perhaps wasn't as effective as it could or should have been, mainly due to some of the unacceptable behaviours in the Trust at the time. I knew that it was out of my control, and there was an element of wanting staff to know me and my strengths in this role. So my passion is improving inpatient care, and I knew at the start of the project that culture had a huge bearing over staff being honest and open. So I was also aware that in the new care group I was working in, women's and children's, it's probably an area that culture was at its best in the Trust. So I didn't primarily want to focus on that, and didn't try to predict the results before it started. So I tried to remain objective. Because I knew the culture had an influence on staff reporting incidents, it was an area of interest, but I knew incident huddles introduced previously were likely to have a positive impact. So as I was evaluating the effectiveness of the huddles, but also identifying areas of improvement, I was excited about finding out staff's opinions. So when I did plan my stakeholder analysis and my stakeholder mapping, I included a lot of staff hierarchically senior, as I was really interested in the strategic bigger picture. But I soon realised that I had to switch my tactic, and arranged for lots of one-on-ones and focus groups with the staff on the ground and the clinical staff that I needed to speak to for understanding the incident huddle's effectiveness. So incident huddles were formed in 2020 for the purpose of improving communications from frontline staff to managers, supporting the operational and quality managers, and following their implementation, there hadn't been an evaluation of the process as to whether it had been successful or not. So the project aimed to answer some questions and implement any changes needed to a process already introduced. The learning would then obviously be shared. So the project discovered key conclusions around the managers' and staff's feelings and around incident reporting, and also the effectiveness of the huddles. So this slide shows how the incident huddles work in our care group. Important considerations are given to the discussion, highlighted in the red circle there, and then the grading of the incidents, followed by, importantly, the action log we create, and the feedback to staff involved directly in the incident, but also by the meetings to all staff, and then that governance around it, so creating the action log, maintaining the action log, and then eventually closing the incident. So huddles, they were actually recommended in the NHS patient safety strategy, as this slide alludes to, in 2020, and they describe it as a short multidisciplinary briefing held at a predictable time and place, focused on the patients most at risk. Effective safety huddles involve agreed actions, informed by visual feedback of data, and provide the opportunity to celebrate success. So they enhance teamwork, they share the understanding of the focus and priorities, and they improve situational awareness. So our care group was actually ahead of the curve when it introduced it in 2020, I think probably before this document was introduced. So that was the value that we've put to the huddles, being really a great innovation. So I used the force field analysis model to highlight the driving and the restraining forces for the need for the project. The project is ultimately a patient safety project with the aim of improving patient safety and staff wellbeing. So the external drivers would be, the CQC targets, staff survey data, with internal staff engagement obviously really important as well in terms of the incidents and financial considerations. And restraining forces being actually the perception of incident reporting being a time-consuming process, lack of psychological safety, lack of succinct processes, and lack of those processes for the monitoring and feedback. The next slide shows the staff survey data. So staff survey data was a huge driver for my project. The staff survey questions focusing around staff engagement, some staff feel they don't feel safe raising concerns around unsafe clinical practice. They feel like the trust won't address it, they aren't given feedback, and they don't take action, it won't happen again. So this table does outline the average across the national trusts, our trust average, and then our care group. So it's just being mindful of actually some of the drivers might be slightly different in the pool of staff where I was doing my research. So this slide indicates the key findings from the project. So the preceding slides will cover how culture impacts staff and managers, how leadership and staff engagement affects incident reporting and the effectiveness of the huddles, how process is actually the key to success, how continuous learning is a key element of incident huddles, how we don't engage patients enough in the process. So this slide shows how the learning points link directly to the implementations. So those 5: culture, engagement, process, learning, and engagement from patients, all indicate staff engagement really. And so the implementations being the learning events, the learning letters, improving huddles through documentation and action plans, and improving communication all the time. So key findings of the project around culture. So some staff, it links really closely to the actual staff survey. So some staff don't receive feedback. Some staff still don't feel safe raising incidents. Some staff, the qualitative data suggests that there's pockets where actually staff do feel safe about incident reporting, which is an important point. And that's where their perception of their leader is a positive one. So where there's strong leadership, and that is where people feel safe raising concerns, which is really key point, I think. So culture is described as the way things are done around here, and it's influenced by a number of factors, including the organisation values and behaviours of the leaders. Patient safety is about maximising things that go right and minimising things that go wrong. And achieving that open, honest patient safety culture, based on research, concludes just culture is the key environment for optimal patient safety. So my report finds that staff interviews, both one-on-one and groups, staff feel most engaged learning from incidents when their service managers involved them in decision making, involved them in action plans, and they were actively encouraged to take part in service improvements. This is a slide as an example of a learning lesson bulletin I produced in July. So it's a communication tactic where we can share successes and processes in the care group. Interestingly, some staff gave me feedback. They didn't like the word learning lessons. The language was perceived as being told off, so I took that from this learning lessons bulletin. Incident data sometimes shows that staff don't always report the right incidents for the right reason. For example, it could be them raising concerns about a frustrating situation they might be in, which isn't the right time to incident report. So my report does show that there's a disconnect between incident huddles and frontline staff receiving the right learning. These letters are there obviously to aid communication. So the report found, although staff and managers felt the huddles were successful, so actually 70% of staff found them effective and the managers found them 100% effective in my data. And it indicated that that perhaps some of the processes could do with some improvements. So before huddles were developed, there was lack of ownership from service managers, there was lack of engagement from service managers, and sometimes a culture of hierarchy of knowledge. So the oversight was by a different team than the actual service manager. So giving a sense of information power, but also a lack of ownership. So this led to a disconnect between quality leads and frustration from service managers. So when undertaking this study and research, the vision was described to all staff participating in the surveys and the end goal communicated as in the Cotter model. Putting these steps in the change process allowed for the disconnect to be rectified. So the report also found, when we think about systems, that the system sometimes isn't easy to manoeuvre. They didn't know how to report an incident. They didn't always feel included in the process. They didn't always have feedback and didn't understand what was happening around them in the care group and themes of incidents. And some staff felt like it was a channel for who was to blame for the incident. So the Trust has embraced learning from the staff. They don't feel that are fairly treated after incident reporting by training investigating officers in the SEEPS model. This is critical, improving staff's perceptions, promoting a human factors culture and a just culture. So the next slide complements the systems approach as the next step of incident reporting success in embedding learning from them. So this is a driver diagram. It was from the Developing People Improving Care document and highlights how staff learning and training impacts directly patient care. Staff felt in my report, that they were aware of the learning lessons. Some managers, so 50% actually, used the learning lessons to attribute to thematic review of incidents. Only 15% of staff felt they evidenced their learning. So that indicates the gap in the learning loop. The evidence from the report indicates there's a good understanding of incidents. Incidents are discussed and some cascade occurs to staff, but the gap is still evident in the governance. So the report recommends to support and encourage staff to reflect, learn and continue to develop themselves and place quality and learning from incidents at the centre of what they do. The introduction of regular learning events in the care group adds to the strategy of supporting this continuous learning. So this study did not directly question the importance of patient involvement. An acknowledgement and a limitation of the research was the exclusion of patient involvement actually in incident reporting process. Patients are part of a system, yet the NHS has tendency to work in silo. Health tends to work in silo, and a major criticism of care in the past has been the lack of joined up care for the patient. So ICS's integrated care system should play a critical role in aligning action between partners to achieve their shared purpose, to improve quality, outcomes, tackle inequalities, enhance productivity, make use of the resources and strengthen the local communities. Patients aren't properly involved in health and social care management and policy. Many patients are unaware of opportunities to get involved in the safety at the organisational and policy level. When they do get involved, it is often tokenistic. If their contribution is actively sought, they are often poorly supported, evidence shows. So some of the barriers I identified on the project. So we've talked about it previously. organisational culture. The organisation hasn't been in a particularly good cultural place, which we've discussed, which wouldn't allow for an environment of continuous learning and positive incident reporting. Staff were sometimes negative regarding the change process, and they felt like culture was so deep-seated and deep-rooted, nothing would change anyway. They believed the blame culture was hard to move on from, and the senior management in the trust was not modelling a great place to work. Patients have not been included in the study, as we've mentioned, and statistics do show that hospitals which involve patients report 38% fewer harmful medical errors and 46% fewer adverse events. And of course, we haven't had time to reevaluate the project. I would hope that engagement figures perhaps would improve following the improvements. And the COVID pandemic obviously contributed to the limitation of the delivery of my project due to the inability to communicate with staff face to face. So using Gibbs model, so the quality project I led was a quality improvement project for patient safety. So I was an insider action researcher and new in post, so I had the enthusiasm for the evaluation and implementation. I used my recognised strengths, organisation skills, strategic influencing and negotiating, and entrepreneur skills. I learned staff wanted to make improvements. Staff were keen to learn, they wanted to be part of the process. I feel like the project has raised awareness of staff to the positive incident reporting. It's allowed staff space to express how they feel. And some positive change has come from the project, for example, the flow of the quality and safety meetings, communication bulletins, learning events have been adapted for our care group, and I do feel like the research could have an impact upon the care system and health and social care as we move into an integrated health system. So my hopes for this project is for managers to take away and leaders the importance of engaging with your staff, being inclusive and promoting conversations about incidents. Low-level incident discussion really does prevent higher-level incidents and improve staff engagement, with the prediction that the engagement figures we saw from the staff survey at the start of the presentation will improve. So those key questions from the staff survey around staff engagement. In conclusion, my project has been an incredible journey. I feel like I've developed so much as a leader, and I've really realised my passion for quality improvement projects. Alongside the project, I've received coaching externally, sought out networks around the UK, identified stakeholders key to my project from other organisations, and now understand my influences and, importantly, recognise my limitations. So I started the journey lacking confidence, with limited skills, and I feel like I've finished where I'm flourishing and have drive and passion. But also remembering the journey is to keep the patients ultimately, which includes myself, my family, my children, my friends, at the centre of everything I do. This realisation for using the power I have in the privileged position I own is key to continuing to be successful, influential in my field of healthcare. Thank you for listening.